Welcome to the FHLIP conference. We are live. Once again, we have a very special guest. So I'm going to hand it over to him so he can introduce himself, and then we'll pick his brain a little bit. So please take it away.
Hi, everybody. My name is Ted Alexander. I'm the Vice President of Partnerships and Clinical Innovation at Amplify Care. We used to be the Health Center of Excellence. So we're a change management company working in 6 provinces across Canada, doing change management adoption work of the, quickly changing innovation space around digital health in Canada.
That's exciting, and being mindful of confidentiality, but are you able to share, like you said, a lot of work you're doing over 6 provinces, some of the projects that you guys are doing, or what's to come that you guys are focusing on as an organization in this coming year, or given that in the healthcare ecosystem, there's so much change with AI or what have you?
Yeah.
Anything you can share with us?
Yeah, I mean the kind of genesis of our work nationally is comes from E-Referral. So we did an innovation procurement in Ontario, and then that really led to um, a great relationship between being a change management company and with primary care and specialists, and then also having a relationship with the vendor because we did a design contest. I'm going to speak about this a little bit later today at the conference. But because we did that work, we really had the relationship with the health system and the users of electronic referral technology, and then also the relationship with the vendor as well as the province to talk about how communication should happen between clinicians around the patient journey. And so then that led to many provinces that were wanting to move into the e-referral space, wanting to talk to us to get our advice because we did that innovation procurement more than like about 10 years ago. And so then as other provinces have been moving away from faxing and moving towards e-referral, they wanted to talk to us. And then it's led to opportunity to kind of do some consulting work to guide them on that. In addition, you talked about AI, which everybody is talking about. And so we were involved in doing the evaluation in Ontario around AI Scribes. And then we've done work in other provinces that with Doctors of BC and Canada Health Infoway about the scribe work, just to understand some nuances about whether they work for specialists in different specialties the same way that they worked in primary care. In addition, that's led us to different opportunities where we've worked with digital twins in AI and clinical decision support in AI and triage and reception work in primary care in AI. So then, different pockets around the country are moving forward, and we're trying to support them as best we can because we know from our experience in change management that there's a lot to understand in terms of how it is that we're enabling improvements in workflows in across the health system.
No, appreciate you sharing that. That's so exciting. And I think you hit on 2 very exciting components, like one being e-referrals. Like you said, we've had faxes around for so long
Yeah.
and tackling that, and then medical AI scribes. So based on that experience, are you able to share what was similar, what was different in those respective realms when you guys were navigating that space, given that they're so critical to the healthcare system? Yeah, I'll hand it over to you.
Yeah. So, I mean, to me, what's similar about them is it's about the communication patterns that exist between clinicians and other groups. So in e-referral, really it's about clinician to clinician communication at the outset, right? Is like, are people getting the right information from primary care to specialists in terms of facilitating the clinical care that a patient needs? Um, in addition, it does involve the clinician to patient. Like there's a bit of a triangle in the way that we developed e-referral in that when a primary care clinician has the patient's email, they're actually getting notices saying that they've been referred to a specialist, and then the specialist can contact the patient to facilitate the booking. So really high satisfaction rates on e-referral from patient side. And so we've embedded surveys into the solution so that we get clinician feedback about how e-referral works and also from the patient side. And so what I often think about is like when I get handed a piece of paper for a referral, what I feel like saying to my doctor is, this really doesn't work for my workflow, right? Like I've got the rest of my life is it's on my phone, right? Like I don't want paper to do this. And I appreciate like, can we move into, a different world? And so patients agree across the country that they want to be included in that process. And then in that clinician to clinician communication, when you take it away from facts, it allows for a bidirectional, collegial relationship.
Yeah.
So I think that sometimes in health systems, there are kind of some power differentials or like just weird distortions that happen when the communication channel's not open, right? So, like a primary care clinician saying to a cardiologist, like, look at their heart, that's not enough information, right? The cardiologist thinking, like, where did you get your medical degree, right? Like that kind of stuff. So then it allows us to kind of level the playing field in a way that actually benefits patients, I think. And it also just allows us to do things like calculate wait times inside a solution and provide them to the referring clinician when the patient's sitting right there. So then patients get more information than they would otherwise, right? The clinician can say in a digital environment, I'd like, there's some different options. There's one that's closer to where you live, but you might need to wait longer. Which one would you rather do? So I'm not sure if I answered your question. Like the similarities, I think on the AI side, I'm getting there, is that really involves the communication space between a patient and a clinician for the most part in terms of the like ambient scribes and digestion of the patient encounter with the clinician. And so like the feedback is overwhelmingly positive, I think, in terms from the patient perspective, in terms of being able to look in
Look at
person in the face like
it.
we are, right?
Yeah.
And I'm not trying to type all of what
Yeah.
I'm saying. Um, and we're also seeing now that patients are asking clinicians if they can bring their patient-centered scribe to the encounter. And so then that I was in a conversation with someone who is a caregiver that was saying how helpful it is for them to get a record of um, you know, uh, a meeting with a specialist because we didn't all go to
Yeah.
medical school,
Yeah.
right? So then we don't know exactly what all the terminology means, and we could use some ability to digest it better afterwards. So I do think that there are similarities between e-referral and that AI scribe work in terms of just thinking about how we can continue to get better at like kind of encoding and decoding communications, right? Like we need help. It's especially on that kind of decoding the meaning of things because um, we just do. We can't like there's stressful times sometimes in these real time meetings, and sometimes we need a family member or a caregiver or somebody to help us make
Exactly.
sense of things, and we want to do it in an accurate way, not
Yeah.
based on memory,
Yeah.
because we know that just doesn't
Yeah.
work. Yeah.
Yeah, no, that's incredible. And I appreciate you kind of sharing that. And the thing where you said that for the e-referrals where they could see the wait times, I think that's so incredible. It reminded me where in the States they said for their ER rooms, the wait times, they would post it on the billboard. So as you're driving by, you
Right.
know what the wait time is. So I think to your point, the more data you have, you can make a more informed decision and kind of navigate this so you can get the care that you need in a timely manner. So I think that's wonderful. The piece about the AI side, that kind of opens a segue to another piece that I wanted to
Sure.
ask you
Yeah.
is that, like we said, in the healthcare ecosystem, there's a lot about AI in all aspects of it, whether on the patient side, on the clinician side, at large in society. So, from your perspective, what are your thoughts in AI as it evolves in terms of empowering or in the healthcare ecosystem at large, whether it's addressing gaps or pain points? So, I know it's a very broad question, but just wanted your thoughts on AI within the healthcare ecosystem and where you kind of see it moving forward, whether it's addressing gaps or however you think it may proceed.
Yeah, I mean, I think the ability for um, AI to help us address gaps, it seems unavoidable. Like the keynote today from Will Falk and Daphne Carr was talking about. I mean, Will's perspective was pretty clearly alongside that. We need to find ways to get this moving forward and not be so risk averse. And where I really agree with him on that, in my head, I've kind of got an old school balancing scale in my mind, and sometimes when we think about the risks that a particular technology might bring forward, we don't talk about them against the risks of the status quo. So I just think we need to test out that promise in a quick way because we know that we need help beyond humans in our health system to have it work more effectively. We just don't have enough clinicians. and we don't have enough medical office assistants, that to be the support structure for the system that we've put forward in our strategy. So we want stronger patient medical homes, and we want everyone to be attached to a primary care group. That's part of our strategy for a stronger health system. We're going to need help that goes beyond humans to allow that service to be what we want, I think. And so to me, I just agree that we need to find the best way possible to add these supports into the system. And then, from that position, we should be thinking about specifically like what types of roles are appropriate to add in that type of technology. So we don't need to start in the most risky place, but we do need to figure out how to get the help we need.
Yeah, no, absolutely. And something interesting you said, comparing the risks to the status quo. Can you give an example when you said that of comparing that?
Sure. I mean, so uh, I think that there's really clear evidence to suggest that there are many breaches of of health information when we use fax machines. There's also um, much more severe patient safety risks with respect to faxing information, right? So we don't know when a fax doesn't go through in a way that reflects the severity of the health system. And so like I know like the Greg's Wings process, that Greg Price's story from Alberta, where he was an engineer, a young engineer who had testicular cancer, and it got lost, and he lost his life because of that. Like that's the type of patient safety risk that we're talking about when we don't act in the most appropriate way. Or not, it's not even that we weren't acting in the most appropriate way. It's like there we didn't have the safe system set up, right? So like that's what I mean, is that we need to have those stories in place where lost information or lack of confirmation cost people their lives. Like that's the severity of it.
Yeah, no, and I completely agree. Alluding to what you said something earlier, that you are presenting at the FHLIP conference. So just to give a nugget and a little bit of a takeaway to the audience of what you'll be presenting on.
Yeah. So in 2017, we published a model around how it is that we do change management. And really, that's about the relationship that people who are bringing technology into a workflow in a health organization, like how they need to think about that process. So 9 years ago, when we were talking about that, we really wanted to focus on what is a clinician trying to produce in terms of clinical value for a patient. They're bringing that medical school knowledge, or like their training and having support for the patient. And then the other thing that they need to think about is they work in an organization, and so they need to make sure that it works for them from an organizational value perspective. So we talked about organizational value when we first wrote about this or published about this. Now there's a lot of information out there about administrative burden, which is just the converse side of that. Right? Is that people are burdened by processes that they weren't signed up for, right? Like nobody went to medical school with the deep desire to fill out an insurance form. But that's part of the workflow. And so when we add technologies, do we add burden to that place? Okay. So then where I'm going beyond that is that as it relates to the work that we've done in E-Referral, we realized that, and this lines up with empirical evidence on successful change management, is that we need to have relationships where the clinician feedback goes into the product development lifecycle around the technologies. So we can start with that change management work that's just like, this is how you're going to enable improvement in your workflow by using a particular technology. But when a clinician says, okay, this is fine for today, but I really need the product to start doing this, that information needs to go back into the companies that are producing the technology so that we keep getting better on it. And I think it's we've been able to do that with some of the work, and we've allowed for product enhancements that's really driven adoption of particular technology and driven acceptance by clinicians and patients in terms of what it's doing for them.
Yeah, no, I couldn't agree more, because I'm on the vendor side. So I agree, us taking the feedback and being involved in that process is very important. So as we wrap up for today, I'll just hand it over to you. One last thing you'd like to share with the audience, anything you would want to touch on as we wrap up?
I mean, I just think that events like this that U of T is hosting is really great for us to continue to work across, like you say, across the vendor and the clinician perspective and with health systems to just keep talking about more openly what value are we actually trying to support with some of the initiatives, and then how is it that we can work together to improve on that, because it's a we haven't done it perfectly right yet, so we've got some more improvement to do.
Yeah, no, absolutely. Well, thank you so much for having this conversation with us and sharing those nuggets and specific examples with e-referrals and medical AI scribes, which we see and need so much. So thank you so much for joining us.
Thanks for having me.